Hello and welcome to the ASCO Daily News Podcast. I'm Dr. Neeraj Agarwal, your guest host of the ASCO Daily News Podcast today. I'm the director of Genitourinary Oncology Program, a professor of medicine at the Huntsman Cancer Institute at the University of Utah, and editor-in-chief of the ASCO Daily News. I'm delighted to welcome Dr. Rana McKay, a geomedical oncologist and associate professor at the University of California, San Diego. Today, we'll be discussing some key abstracts in genitourinary oncology featured at the 2024 ASCO Annual Meeting. Our full disclosures are available in the transcript of this episode. Rana, we are thrilled to have you on the podcast today to share your insights on key advances in geo-oncology from ASCO 2024.
Thank you so much, Neeraj. It's a pleasure to be here.
So, Rana, let's start with some bladder cancer abstracts. Could you tell us about abstract 4503 titled Impact of Exposure on Outcomes with enfortumab vedotin or EV in patients with locally advanced or metastatic urothelial carcinoma?
Of course, I'd be delighted to. First, I would like to remind our listeners that enfortumab vedotin was approved as a monotherapy for the treatment of locally advanced or metastatic urothelial cancer based on the results of EV-201 and EV-301 trials. In these pivotal studies, EV was initiated at a dose of 1.25 mg per kg, and dose modifications such as reductions and interruptions were used to manage adverse events. In the abstract presented at ASCO 2024 by Dr. Dan Petrolak and colleagues, they conducted a post hoc exploratory analysis to evaluate the association between EV plasma exposure and outcomes. They used multiple pharmacokinetic samples collected during the first 2 cycles and pre-dose samples from 3 EV monotherapy studies, namely EV-101, EV-201, and EV-301, that were conducted in patients with previously treated locally advanced or metastatic urothelial carcinoma. Dose reductions to 1 mg per kg were required in 41% and 35% of patients in the EV-201 and 301 trials, respectively, and reductions to 0.75 mg per kg were required in 14% and 11% in the EV-201 and 301 trials, respectively. Higher EV exposure during the first 2 cycles was associated with a higher objective response rate, and the objective response rate was 21% for the dose of 0.75 mg per kg, while it was 18.5% for the dose of 1 mg per kg. So interestingly, increasing the dose to 1.25 mg per kg improved that objective response rate to the range of 40 to 51% across various studies. So in the EV-301 trial, when comparing the efficacy of EV to chemotherapy, EV improved PFS and OS across all dose quartiles, and there was no evidence that recommended dose modifications impacted long-term efficacy outcomes.
Thank you, Rana, for this great summary. I would like to add that these meticulously conducted pharmacokinetic studies demonstrated that serum levels of enfortumab vedotin correlated with responses. And importantly, patients who had to decrease the dose did not experience compromised outcomes when you compare the responses of EV to chemotherapy in the EV-301 trial. And these findings highlight the need to start at the recommended dose of 1.25 milligram per kilogram and reduce the dose if necessary because of the side effects. But we should not really start the dose of EV at a lower dose at the outset.
I totally agree with you, Neeraj. Now moving on to a different setting in bladder cancer. What can you tell us about late-breaking abstract 4517 titled Perioperative Sacituzumab Devotecan alone or in combination with pembrolizumab for patients with muscle-invasive urothelial bladder cancer, or the SURE-0102 interim results?
So SURE was a multi-cohort, open-label, phase 2 study in patients with muscle-invasive bladder cancer, assessing sacituzumab govitecan as a neoadjuvant therapy, either alone in SURE-01 trial or as a combination with pembrolizumab followed by adjuvant pembrolizumab in SURE-02 in a flexible design allowing a bladder-sparing approach. So in the abstract presented at the ASCO 2024 meeting, Dr. Antonio Sigliola and colleagues report interim results of the SURE-01 study. So patients with clinical T2 to T4, N0, M0 urothelial carcinoma who were ineligible for or refused cisplatin-based neoadjuvant chemotherapy were planned to receive 4 cycles of neoadjuvant sacituzumab govitecan at a dose of 10 milligram per kilogram, followed by radical cystectomy. An extensive assessment was performed at baseline and after the 4 cycles for response assessment. Patients with clinical complete response, defined with negative MRI, cystoscopy, and ctDNA assay, refusing radical cystectomy, were offered a repeat transurethral resection of bladder tumor or repeat TURBT followed by observation in the absence of viable high-grade tumor in the bladder. The primary endpoint was pathologic complete response rate, while secondary endpoints included pathologic downstaging rate and safety. After the first 8 patients were enrolled, the protocol was amended due to the occurrence of grade 3 and 4 neutropenia and diarrhea in 75% and 50% patients, respectively, and 2 deaths, one of which was deemed to be related to the treatment due to sepsis. Key protocol changes included the reduction of the dose of sacituzumab govitecan to 7.5 milligram per kilogram, the introduction of GCSF as the primary prophylaxis, and the exclusion of patients at high risk of febrile neutropenia per ASCO guidelines. So among 21 patients who received at least 1 cycle of sacituzumab govitecan and included in the intention to treat population, 48% patients had a complete pathologic response and 52% patients had pathologic downstaging. 11% patients underwent radical cystectomy, while 7 received a repeat TURBT due to complete clinical response or patient preference. Regarding the safety profile, grade 3 or 4 more adverse events occurred in 42.5% patients, and treatment-related adverse events leading to dose interruptions or discontinuations were more common before the protocol amendment. I would like to highlight that 3 patients died after treatment discontinuation, with 1 deemed treatment-related, as I previously mentioned. So, toxicity profile was a concern in my view.
Thank you, Neeraj, for such a great summary. The pathologic complete responses observed show promising activity for sacituzumab govitecan as a neoadjuvant therapy and a window for bladder-sparing approaches, which is definitely exciting news for our patients. However, the 3 deaths encountered in the neoadjuvant setting could be concerning. The improvement of the safety profile after protocol amendments is certainly reassuring and supports continuation of the study. So it's going to be interesting to see how this pans out.
So before wrapping up the bladder cancer section, would you like to share your insights with our listeners on abstract 4518 titled Quantitative Circulating Tumor DNA Assessment in Patients with Advanced Urothelial Carcinoma treated with pembrolizumab or platinum-based chemotherapy from the phase 3 Keynote 361 trial?
So the Keynote 361 trial was a randomized phase 3 study with 3 arms that included pembrolizumab plus chemotherapy, pembrolizumab monotherapy, or chemotherapy alone in patients with previously untreated advanced urothelial carcinoma. The results showed that neither the combination of pembrolizumab plus chemotherapy nor pembrolizumab monotherapy improved survival outcomes compared to the chemotherapy arm. In this exploratory analysis presented in ASCO 2024 by Dr. Tom Powles and colleagues, they sought to assess the role of circulating tumor DNA as a potential biomarker between the pembrolizumab monotherapy arm and the chemotherapy arm. Tumor tissue mutations were evaluated using whole exome sequencing, and plasma ctDNA was assessed with the Guardant 360 assay. Changes in ctDNA from pretreatment cycle 1 to on-treatment cycle 2, so 3 weeks post-baseline assessment, were quantified by the maximum variant allele frequency of tumor tissue-specific mutations. Results showed that lower baseline ctDNA levels were associated with improved clinical outcomes of response to pembrolizumab, but not chemotherapy. And this improvement in the pembrolizumab arm was also robust to adjustment for TMB and PD-L1 status. Additionally, chemotherapy led to a ctDNA clearance rate of 41% compared to 11% in the pembrolizumab arm. And patients who had a larger ctDNA reduction with pembrolizumab had significantly improved outcomes compared to those achieving a large reduction with chemotherapy, with a hazard ratio of 0.25. However, this did not replicate in patients who did not achieve a larger reduction, as those patients had similar outcomes across both arms. So this data are really quite interesting about the integration of ctDNA in patients with advanced metastatic urothelial carcinoma receiving frontline therapy. So let's switch gears to kidney cancer and start with abstract 4508, reporting the final OS analysis from the Javelin Renal 101 trial. Neeraj, would you like to take us through this abstract?
Well, as a quick reminder, the Javelin Renal 101 was a randomized phase 3 trial where patients with previously untreated advanced or metastatic renal cell carcinoma with clear cell type were randomized to receive either the combination of avelumab plus axitinib or sunitinib. In previous analysis, the combination of avelumab and axitinib significantly improved progression-free survival compared to sunitinib and was thus approved by the FDA for the first-line treatment of patients with advanced RCC in 2019. This superiority in PFS was maintained across the different analyses. However, OS data remained immature. In the abstract presented in ASCO 2024 by Dr. Bob Moser and colleagues, the authors reported overall survival results at a median follow-up of around 73 months and a minimum of 68 months for all patients. And this is the longest follow-up for any ICI-TKI combinations in the renal cell carcinoma setting. So the final analysis in the overall population favored the combination of avelumab plus axitinib with a median OS of 44.8 months compared to 38.9 months with sunitinib. However, this did not reach statistical significance with a hazard ratio of 0.88. The progression-free survival results and safety profile were consistent with previous analysis.
Thank you, Neeraj, for such a nice overview of this abstract. These new data could make this regimen less optimal than other ICI-TKI combinations in the first-line metastatic RCC setting.
I agree with you, Rana. It's a 6-month improvement in survival with the ICI-TKI combination, but still not statistically significant. So let's move on to one of the most exciting GU abstracts featured in the meeting, and this was abstract 4506 titled Circulating Kidney Injury Molecule 1, Biomarker Analysis of Emotion 010 trial, which was a randomized phase 3 study of adjuvant atezolizumab versus placebo in patients with renal cell carcinoma at high risk of recurrence after resection. So, Rena, what are your thoughts on this abstract?
Well, I think I completely agree with you that this was probably one of the most exciting abstracts that we saw within the GU space. So first, I'd like to step back and remind our audience that in the Emotion 010 trial, patients with resected intermediate to high risk RCC with clear cell and or a sarcomatoid component were randomized in a 1-to-1 ratio to receive either atezolizumab or placebo. Investigator-assessed disease-free survival, which was the primary endpoint, favored the atezolizumab arm but did not reach statistical significance. In the abstract featured at ASCO 2024 by Dr. Laurence Albages and colleagues, they built on data previously reported in the ASSURE and the CheckMate 914 trials that reported provocative findings regarding a molecule known as kidney injury molecule 1, or KIM1, which is a type 1 membrane glycoprotein that has been identified as a minimally invasive potential peripheral blood circulating biomarker. So this is a blood-based biomarker. The KIM1 level of 86 picograms per milliliter was identified as the optimized threshold for defining post-nephrectomy KIM1 high versus KIM1 low subgroups in the EMOTION 010 trial. KIM1 levels were measured at baseline or pretreatment, at cycle 4, day 1, and at disease recurrence or discontinuation without disease recurrence. Baseline characteristics were balanced between the KIM1 high and KIM1 low groups, except perhaps for a slightly higher pathologic stage in the KIM1 high group. I would like to highlight 3 key takeaways from this abstract. First, KIM1 high levels was associated with significantly worse disease-free survival with a hazard ratio of 1.75. Second, patients in the KIM1 high subgroup receiving atezolizumab had a 28% reduction in the risk of recurrence or death compared to receiving placebo, while those in the KIM1 low subgroup had comparable outcomes across both treatment arms. Third, patients in the KIM1 high group receiving atezolizumab were significantly less likely to experience an on-treatment increase in KIM1 levels, which was associated with worse DFS in both the high and low subgroups, regardless of the treatment arm. So what these findings really support is the use of KIM1 as both prognostic, but also a predictive biomarker to IO therapy in the adjuvant setting. This is really quite exciting.
Yes, Rana, just amazing data. I would like to add that these results warrant larger and ideally prospective studies to validate the utility of KIM1 as a non-invasive biomarker for identifying minimal residual disease after nephrectomy and for predicting outcomes to immune checkpoint inhibitors. And I'm really hoping we'll soon have a validated biomarker to select patients for adjuvant therapy in our clinic.
That would be exciting. Also in the field of biomarkers and kidney cancer, there were 2 abstracts interrogating different biomarkers in a different setting. So for patients with advanced or metastatic RCC as opposed to the localized setting. Neeraj, could you tell us more about these 2 abstracts?
Of course. And I think you're referring to abstract 4504 and 4505. In the abstract 4504, Dr. Tony Choueiri and colleagues sought to assess the clinical implications of different biomarkers in the CLEAR trial, which was a randomized phase 3 trial that led to the approval of the combination of lenvatinib plus pembrolizumab in the first-line metastatic RCC setting. Regarding the other abstract, the abstract 4505, Dr. Brian Riney and colleagues presented biomarker results in the Keynote 426 trial, which was also a randomized phase 3 trial, based on which the combination of pembrolizumab plus axitinib was approved for patients with advanced or metastatic RCC. So the authors in both trials sought to interrogate the role of biomarkers in predicting treatment outcomes from 3 different angles. So starting with the PD-L1 expression by the tumor, the superiority of the combination arms over sunitinib was not impacted by the tumor PD-L1 status in both trials. And then moving on to the RCC driver gene mutations on whole exome sequencing, such as VHL, SETD2, PBRM1, and BAP1, ICI combination therapies improved outcomes regardless of mutation gene status, and this improvement was statistically significant with PBRM1 mutation in the Keynote 426 trial compared to wild type PBRM1, but it did not replicate in the CLEAR trial. And finally, using the transcriptomic signatures derived from the RCC trials, especially the Emotion 151 and the Javelin Renal 101 trials, where 7 clusters or molecular subtypes were identified, the combination ICI TKI arms outperformed sunitinib in all clusters in both trials, although the magnitude of this benefit differed across clusters. So, to summarize, in both these phase 3 trials, in very elegantly done, robust work done on biomarkers and correlating those biomarkers with the outcomes, we really did not see any one particular biomarker predicting superior response to ICI TKI combination over sunitinib.
Thank you for this very interesting summary and comparison of the results of these two abstracts. These findings support the use of immune checkpoint inhibitor-based combinations in all patients with metastatic RCC as a first-line option. And although these abstracts could not identify specific biomarkers that could guide us clinicians in treatment selection, they provide very interesting biological insights on these molecular biomarkers that are, however, not yet clinically actionable. So I think these data are really quite important.
Yeah, very interesting point, Reina. So moving on to prostate cancer, let's start with abstract LBA 5000 titled Cabazitaxel with abiraterone versus abiraterone alone randomized trial for extensive disease following docetaxel. So the charter trial of the ECOG Akron Cancer Research Group, EA8153. Reina, what is your takeaway on this abstract?
Now, this is a wonderful abstract, and it's always really exciting when we see data that gets presented from our cooperative groups from studies that have been run across centers across the US. And as a reminder to our audience, the Charted 2 trial was a randomized open label phase 2 study that compared the combination of cabazitaxel and abiraterone to abiraterone alone in patients with metastatic castration-resistant prostate cancer previously treated with ADT plus docetaxel in the metastatic hormone-sensitive setting. So this trial was conducted as the treatment landscape for MHSPC was evolving. The primary endpoint was progression-free survival. After a median follow-up of 47.3 months, Dr. Kyriakopoulos and colleagues reported that patients receiving the combination of cabazitaxel plus abiraterone had a 27% reduction in the risk of progression or death. However, there was no significant difference in overall survival between the two arms, with a median OS of 25 months in the cabazitaxel abiraterone arm and 26.9 months in the abiraterone arm, although the study was underpowered for the overall survival endpoint. Regarding the toxicity profile, the combination of cabazitaxel and abiraterone was overall well tolerated, with more cytopenias as would be expected.
Very nice summary of this abstract, Reina. I would like to add that treatment landscape of patients with metastatic hormone-sensitive prostate cancer has evolved since the design of the study and now includes combination therapies of ADT plus ARPI with or without docetaxel. And ADT plus docetaxel is no longer a standard of care, which limits the applicability of these results in clinical practice today.
Excellent point, Neeraj. So let's discuss abstract 5001 titled Cyclone 2, a phase 3 study of abemaciclib with abiraterone in patients with metastatic castration-resistant prostate cancer.
Sure. In this abstract, featured in ASCO 2024, Dr. Matthew Smith and colleagues, and we were all there involved in this study, reported the primary results of the Cyclone 2 trial, which was a randomized phase 2-3 study that investigated the combination of abemaciclib plus abiraterone versus abiraterone monotherapy in patients with metastatic castrate-resistant prostate cancer. The stratification factors included radiographic progression at study entry, presence of measurable disease, and prior docetaxel chemotherapy for hormone-sensitive state. So the part 1 of the study established the recommended phase 2 dose of abemaciclib at 200 milligram twice daily. In part 2, patients were randomized to placebo or abemaciclib, and an adaptive interim analysis using pre-specified criteria was performed and recommended the expansion of the study to part 3. The primary endpoint was investigator assessed radiographic progression free survival by RECIST 1.1 and the PCWG3 criteria in the intention to treat population. At the time of primary analysis, adding abemaciclib to abiraterone did not improve radiographic progression free survival with a hazard ratio of 0.83. The median rPFS was 22 months for the combination arm and 20 months for the abiraterone arm. The combination was well tolerated and the safety profile was consistent with known adverse events.
Thank you for this great summary. So the addition of abemaciclib to abiraterone did not improve outcomes in patients with metastatic castration-resistant prostate cancer. These findings suggest that no further investigation is warranted for abemaciclib or CDK4/6 inhibitors in biomarker unselected patients with prostate cancer.
I agree, Rena. So, what is your take home message on Abstract 5006 titled Health Related Quality of Life Results from PRESTO or AFT19 trial, a phase 3 randomized trial of intensification of androgen blockade in patients with high risk, biochemically relapsed, castration sensitive prostate cancer?
So, as a reminder to our audience, the PRESTO trial was a randomized phase 3 study that assessed the effects of intensified androgen receptor blockade in patients with biochemically recurrent prostate cancer following local therapies. Patients with a PSA doubling time of less than 9 months and no evidence of metastatic disease on conventional imaging were randomized to receive either 52 weeks of ADT alone, ADT plus apalutamide, or ADT plus apalutamide plus abiraterone. In their paper published earlier this year in the Journal of Clinical Oncology, the author showed that patients receiving ADT plus apalutamide with or without abiraterone had significantly longer PSA progression-free survival than those receiving ADT alone. In the oral presentation featured at ASCO 2024, Dr. Ronald Chen and colleagues reported on the health-related quality of life outcomes that were assessed using various questionnaires or scales at baseline, at cycle 7, which is around 6 months on treatment, and at the end of treatment. The results showed that this intensified approach with apalutamide did not significantly increase severe adverse events, did not lengthen the time to testosterone recovery, and did not meaningfully increase common treatment-related symptoms such as hormonal symptoms, sexual dysfunction, hot flash interference, and fatigue. Importantly, additional intensification with abiraterone did not further improve PSA PFS, but did increase the rate of serious adverse events and lengthening the time to testosterone recovery with increased hot flash interference.
Very nice summary. So, in conclusion, the PRESTO trial supports using intensified androgen blockade with apalutamide to improve PSA progression-free survival in patients with high-risk biochemically recurrent prostate cancer without compromising health-related quality of life. However, adding abiraterone did not offer additional benefit and increased side effects.
Moving on to abstract LBA 5002, namely a randomized, double-blind, placebo-controlled trial of metformin in reducing progression among men on expected management for low-risk prostate cancer, the masked metformin active surveillance trial study. Would you like to share your insights on this abstract with our listeners?
Absolutely. So, MAST or MAST was a randomized, double blind, placebo controlled trial that investigated the impact of metformin on the progression of low-risk localized prostate cancer in patients choosing to undergo active surveillance. Eligible patients had biopsy-proven low-risk localized prostate cancer diagnosed within the past 6 months, characterized by a Gleason score of less than 6, observed in less than one-third of the total course, less than 50% positivity in any one core, a PSA level of less than 10 nanogram per mil, and a clinical stage between T1C and T2A. So it was a very rigorously defined low-risk prostate cancer population. Patients were randomized in a 1-to-1 ratio to receive either metformin 850 milligram twice daily or placebo for 3 years. All patients underwent repeat prostate biopsy at 18 and 36 months. The primary endpoint was time to progression, defined as the earliest occurrence of primary prostate cancer treatment, such as prostatectomy or radiation or hormonal therapy or pathologic progression on subsequent biopsies, which was defined again very rigorously as more than one-third of total course involved, with at least 50% of any core involved, or a Gleason pattern of 4 or higher. So now let's look at the study numbers, number of patients who were enrolled, and the study results. So the study included 407 patients, with 204 receiving metformin and 203 patients receiving placebo. Results presented by Dr. Anthony Joshua showed no statistically significant difference in progression-free survival, including therapeutic or pathologic response progression, with an unadjusted hazard ratio of 1.08. Interestingly, there was a signal that patients with a BMI more than 30 had a detriment to taking metformin with a higher risk of progression compared to those receiving placebo with an unadjusted hazard ratio of 2.39 and a p-value of 0.09. So just to summarize, adding metformin to the treatment regimen of patients who were undergoing active surveillance for low-risk localized prostate cancer did not help, and there was a potential for harm in patients who had a BMI of more than 30 with metformin.
Thank you for this great summary. I would like to add that this study showed that metformin use does not prevent the progression of low-risk localized prostate cancer on active surveillance. It could present a potential detriment for patients with a high BMI at study entry.
So, Rana, any final remarks before we conclude today's podcast?
Thank you, Neeraj. It's been really wonderful being here with you today and you having me on the podcast to highlight these important advances and the amazing work that many investigators are conducting and the patients that were involved in the context of these trials. It's really excellent to see these updated results.
Before we wrap up this podcast, I would like to share that we have reviewed a selection of abstracts addressing prostate, bladder, and kidney cancer, which are significantly impacting our medical practice now and in near future. Rana, thank you for sharing your insights today. These updates are undoubtedly exciting for the entire geo-oncology community, and we greatly appreciate your valuable contribution to the discussion. And thank you to our listeners for joining us today. You will find links to the abstracts we discussed today on the transcript of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcast. Thank you very much for your kind attention.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.